Hello, this is Chris Ferrigno. Today we will discuss the posterior shoulder. We have a wonderful black and white image of the posterior shoulder. This would be the scapular spine extending out into the acromion process. This would be the proximal humerus with muscles underneath that scapular spine attaching the scapula to the proximal humerus. Muscles superior to the scapular spine that aren't shown but we see just in white that would be extending down, inserting onto the proximal humerus. And this, I think this is likely the trapezius muscle going into the acromion itself. Previously, we've seen the muscles of the superficial back. You can see those here in this image and also here in this image. Notice underneath these muscles of the superficial back were the rhomboids that we can see here. But we're going to turn our attention a little further laterally, lateral to this medial border. So we have the medial border. We're going to extend laterally and look at muscles that extend from the scapula, either inferior to the scapular spine or superior to the scapular spine, and go insert onto the humerus. Now note that we have some vertebral landmarks here. So where the scapular spine comes into the medial border, this is roughly T4. Where the inferior angle of the scapula is located would be roughly at the T7 vertebral level. And then, of course, we have the iliac crest coming in at L4, providing a safe location to perform a spinal tap or withdrawing cerebrospinal fluid. So let's look at some pertinent osteology. We've seen a lot of this already, but we'll name some newer structures that we haven't discussed yet. So we've seen already an inferior angle and a superior angle, and a medial border and a lateral border. Here we have that spine of the scapula. We're looking posteriorly. We're looking at a view like this posteriorly, by the way. So we have the spine of the scapula extending around through the acromion process, which ultimately articulates with the clavicle anteriorly. So because we have this spine, if we go into this fossa or cavity above the spine of the scapula, we're going to call that the supraspinous fossa. So that makes sense. And below the spine of the scapula, we'll have an infraspinous fossa. Recall, laterally we have the glenoid cavity or the glenoid fossa. And so just inferior to that glenoid cavity or glenoid fossa is the infraglenoid tubercle. So it's this entire tubercle here, which is going to provide a site of attachment for the triceps muscle. If you have an infraglenoid tubercle, you probably have a supraglenoid tubercle. That's going to be up of the northern edges of the glenoid cavity, but we don't see that here in this view. The acromion process is getting in our way. Anteriorly, we're going to have a coracoid process and several muscles attached to that, but we can't really make out a nice view of that coracoid process right now. Dipping down as we go medially from the coracoid, we're going to have this notch. This is called the suprascapular notch. And that suprascapular notch is going to communicate with the superior border. Recall that in this area we had the levator scapula coming off of the superior angle. Off of the medial border we had the rhomboid minor and the rhomboid major attaching. And we've had muscles already attached to the spine of the scapula. We've had the trapezius muscle come off this area here. And we're going to ultimately see the deltoid come off the spine of the scapula as well. So once again, we have this suprascapular notch. We have a yellow line going across here. We're going to name that line a little later. We're going to call that the superior transverse scapular ligament. The superior transverse scapular ligament. And that's going to create an opening here. Now note, the spine of the scapula as it extends laterally, it's going to become somewhat detached, so there'll be an opening here. It'll become somewhat detached from the body of the scapula. So there's a notch here that communicates from the infraspinous fossa to the supraspinous fossa. And that notch is called the greater scapular notch or the spinoglenoid notch. I prefer the former, the greater scapular notch. So here we have the same scapula but turned around. And just to orient you, here we would have the spine, and over here would be the head of the humerus, with the humerus going down this way. So we're on the anterior view. You can see this very large subscapular fossa here. Within this, we're going to find the subscapularis muscle, so that makes sense. Here we can see that same infraglenoid tubercle with the supraglenoid tubercle again obscured now by the coracoid process. This is the coracoid process. It's a very robust bony prominence that comes out anteriorly. We're going to see 3 muscles, if I'm not mistaken, come off of this coracoid process. Otherwise, we have the same landmarks. We have the lateral border, we have the medial border, superior and inferior angles in the superior border. Here we can see the suprascapular notch between the coracoid process and the superior border. So here we can see that supraglenoid tubercle. It's a bit of a lip over the glenoid cavity. Onto this supraglenoid tubercle attaches the long head of the biceps brachii. And onto the infraglenoid tubercle we have the attachment for the long head of the triceps. So now let's turn our attention to the proximal humerus. Again, just to get some orientation here, this would be the glenoid cavity extending that way. So this would be the far lateral extent of the proximal humerus. This is the greater tubercle. Anytime you see a bony outcropping like this, you can bet that there's going to be some muscular attachments, and that's definitely true for the greater tubercle. Here we have the lesser tubercle. Note this is more anterior than this greater tubercle. In between the lesser and greater tubercle is this intertubercular sulcus. So inter, right, between, and the tubercles here. So intertubercular sulcus or groove. And residing in that groove is the long head of the biceps tendon. So it's a tendon that just nests itself right in there. There's a little ligament here called the transverse humeral ligament. Let's quickly draw that in here. So we'll call that the transverse humeral ligament that holds this biceps tendon in place as it's heading toward the supraglenoid tubercle. So we have this greater tubercle, the lesser tubercle, the intertubercular sulcus. And note that within the floor of the sulcus, we have muscular attachments, and to the lateral lip of the sulcus, which is an extension of the greater tubercle, and the medial lip of the sulcus, which is essentially an extension of the lesser tubercle, we have muscular attachments as well. I'm not all that concerned that you know specifically which muscles attach onto which lip. However, you should know that the pec major, the teres major, and the latissimus dorsi all connect in to this region. The teres major taking a medial route, as does the latissimus taking a medial route, and the pectoralis going over the top. We'll see this more in subsequent slides. Further distally, we see the deltoid tuberosity, and as you may have guessed, this is going to be the site of attachment for the deltoid muscle, which is overriding the entire shoulder region. Here we can see 2 structures called necks. The anatomical neck sits between the head of the humerus, which articulates with the glenoid fossa, or glenoid cavity, and the tubercular region here, or the shaft. So again, this anatomical neck sits between the head and the shaft of the humerus. And then the surgical neck. Why is it a surgical neck? Well, you can imagine that if you're going to replace this bone, this part of the bone, they're going to cut here. So this is the area where the humerus will be surgically fractured to put a new humeral head on. As you can imagine, this brings up some questions post-surgery. If you remove this whole structure and you have many muscles inserting here and here, what does the surgeon do? Well, he or she is, once cutting here and putting in the new head, will take those muscles and put them back on the appropriate locations as best as they can. Now, in this surgical neck region, we have a couple key structures. One is going to be an artery. We're going to see this again, but for right now, it's called the posterior humeral circumflex artery, and it courses with a key nerve, the axillary nerve. The nerve innervates the deltoid and another muscle called the teres minor. With a fracture, especially if it's a compound fracture or something that splinters, you can imagine that this neurovascular bundle could be compromised. Therefore, if you suspect a patient of having a surgical neck fracture, you want to make sure that the axillary nerve is intact by testing the muscles and the cutaneous innervation of that nerve. And you also want to look for any signs of a lesion of a vessel in the region. Further distally, we have a structure called the radial groove, that's also known as the spiral groove. Within this radial or spiral groove is another neurovascular bundle. You have the deep brachial artery, which comes off the brachial artery. This will all make much more sense once we take a look at the entire structure. And the radial nerve, which we see in the axilla coming off the brachial plexus as a terminal branch. Radial nerve and deep brachial artery course roughly in this region. Let's draw that in. Here's that deep brachial artery spiraling around the humerus and then going that way. If we go to yellow, we'll draw in the nerve. Here's the radial nerve. Same thing, same course, following with the artery. That originated from the brachial plexus, the radial nerve, and the deep brachial artery originates from the brachial artery. Again, this is a posterior view, so we can see it spiraling around posteriorly. So here's another image of that biceps brachii long head tendon. It's coming up here. This is the tendon itself going under this transverse humeral ligament to ultimately insert somewhere around here on that supraglenoid tubercle. We see the synovial sheath that it's coursing through. This allows for nearly frictionless movement within this connective tissue. I'd also like to point out the glenohumeral ligaments, the superior, the middle, and the inferior ligament. Here we can see the superior, the middle, and the inferior, mostly helping to support the anterior glenohumeral joint. We'll discuss more about the glenohumeral joint in the joints of the upper extremity discussion. Before we go into the specific muscles in the posterior shoulder, I want to discuss just for a minute where these nerves are coming from. They will all be coming from the brachial plexus, as do all the nerves that serve the arm. This is the beginning of the brachial plexus. This would be spinal nerves or ventral rami from C5, 6, 7, C8, and T1 that coalesce and take various routes to ultimately output 5 terminal branches: the axillary nerve, the ulnar nerve, the radial nerve, the median nerve, and the musculocutaneous nerve. Along the way, however, they give off some other branches, and this will all become evident in a few lectures from now when we talk about the axilla and the posterior triangle of the neck. But for now, just realize that all the nerves we're going to talk about come from the brachial plexus. We've already seen the dorsal scapular nerve in the superficial back serving the rhomboids and levator scapula muscle. We've seen the thoracodorsal nerve serving the latissimus dorsi muscle. We've seen the radial nerve coursing through the radial or spiral groove in the humerus. However, we don't know yet what it innervates. So we're going to touch on these other nerves today, the ones outlined in red. While we're on the slide, note that we have this big red artery coursing through the brachial plexus. This is called the axillary artery. So let's start looking at the muscles of the posterior shoulder by looking at the rotator cuff. So what is the rotator cuff? Well, it's comprised of 4 muscles in and around the scapula that attach onto the humerus, and they primarily help to stabilize the glenohumeral joint, or the shoulder joint. So let's write that in. First duty is to stabilize. Second duty is to move the shoulder in a few directions. Which directions? Well, they're going to be external rotators, abductors, and internal rotators. They certainly can help do other motions as well. They slightly adduct on occasion. They can slightly flex, slightly extend maybe, but these are the primary movers. And we'll see how that works in just a minute. So I just can't overemphasize the fact that if we didn't have a rotator cuff, our shoulder joint would be highly unstable. We see the location here of the proximal humerus. This humerus, if we had a palsy on the right side, if our upper extremity was affected, this humerus would drop down so that this location right here would end up being down here. That would be a sublux joint, and that would cause a lot of discomfort for the patient. Obviously, they would have a dysfunctional shoulder, and they would also most likely have pain from the traction of these soft tissue structures in here. So here, posteriorly, we can see 3 of the 4 muscles, and they're shown in blue. We have the supraspinatus, which is above the scapular spine. We have the infraspinatus, which is most of the muscle within the infraspinous fossa, along with the teres minor, which is on the inferior margin, at least laterally, within the infraspinous fossa. It comes from the lateral border. So those are the posterior muscles belonging to the rotator cuff. And then anteriorly, we have one muscle, the subscapularis, that is in the subscapular fossa. Now let's take another view of this construct here of the rotator cuff. This is a lateral view, so we're looking at the glenoid fossa, or glenoid cavity. Here we would have the cavity itself, and outlined in blue, the fibrocartilaginous glenoid labrum, and coming off of that in green would be the joint capsule. So outside of that joint capsule, superiorly, almost 12 o'clock position, would be the supraspinatus muscle. Here we can see mostly the cross-section of the tendon approaching the humeral head, or the greater tubercle, I should say. Posteriorly, we have that infraspinatus, and just below it the teres minor. So we have these 3 muscles of the rotator cuff are seen from the posterior view. Thus we see all 3 of them right here. Anteriorly, we have the subscapularis muscle coming in to attach onto the lesser tubercle. And we'll see that. We can see that here as it's crossing the glenohumeral joint to attach onto that lesser tubercle, which is seen right there. So here again we can see the 3 muscles of the rotator cuff from the posterior view, the supraspinatus, the infraspinatus, and the teres minor. Here we can see the supraspinatus muscle originating from the supraspinous fossa, and extends laterally and inserts onto the greater tubercle of the humerus. Now note, en route, it courses underneath the acromion process and anteriorly the coracoacromial ligament. Jumping back to this image, here we can see that supraspinatus coursing underneath the acromion, and this would be that coracoacromial ligament. Sometimes they're in close proximity to one another. Note that there is this subacromial space. I'm outlining what seems to be the structure in green. However, that's a bursa. That's a subacromial bursa. I'm really trying to outline the space. So note that there is only a little bit of space between the tendon of the supraspinatus and the acromion process and this ligament. This produces some problems, mostly in the form of what's called impingement syndrome of the supraspinatus tendon as it's coursing underneath the acromion process, where the acromion or the ligament digs into and breaks down the supraspinatus tendon, causing a tendinosis or a tendinitis. You can see if it contracts, it's going to end up bringing the humerus up into abduction. Now there's always a little point of confusion, so let's get this straight. The supraspinatus helps with the first 10 to 15 degrees of shoulder abduction. So we'll put this here. We'll put 10 to 15 degrees. Now we have a muscle that's overlying this called the deltoid muscle. And I'll just bring this down here like that. Because of the orientation of the deltoid, if it contracts, pulling the humerus, it's going to just drive the humerus up into the acromion process. So it's going to just take this upward pull of the acromion. Because of this arching orientation of supraspinatus, during the first 10 to 15 degrees, to help the arm to get to, let's say, here, the supraspinatus is going to do most of the work. After that, the deltoid is a much bigger muscle. It's going to do a lot more abduction after 15 degrees. But that doesn't mean the supraspinatus is not working during that time. It certainly can help to do motion after those 10 to 15 degrees of motion. I hope that's clear. So during 10 to 15 degrees, that's supraspinatus, and maybe a little bit of deltoid, and then greater than 15 degrees, we're going to put deltoid here, and then supraspinatus. I hope that's clear. Let me clear the screen. Now we can see the action of the infraspinatus. So it's coming from the infraspinous fossa and extending over to insert onto, again, the greater tubercle. Because of its orientation, really just posteriorly, it's going to be a rotator. So if it contracts, it's going to spin this humerus, see if I can do this, around that way. So it's going to be a lateral or external rotator. And it can't do much else than that because it is crossing the joint in this location here. Teres minor is also going to attach here on the scapula, but more on the lateral border, and attach onto the lower margins of that greater tubercle. It's also going to spin the humerus laterally or externally rotate it. Looking anteriorly, we can see this subscapularis, once again filling the subscapular fossa. Emanating from this fossa, here we can see this huge fossa and this very large footprint of the subscapularis muscle, and it's extending over to insert onto the lesser tubercle. To internally rotate or spin this humerus inward or medially rotate the proximal humerus. I want to emphasize the purpose also of the subscapularis, along with the other three rotator cuff muscles, to bring the glenohumeral joint together, or to bring the humeral head into the shallow glenoid fossa. So again, it's here to stabilize the glenohumeral joint. I also want to point out a couple more things while we're here. This is the latissimus dorsi coming in and inserting onto the anterior and medial aspect of the proximal shaft of the humerus. So this will also be able to inwardly rotate, as well as this muscle. This is the teres major muscle, in addition to be a strong adductor and extender, as well as the lat being a strong adductor and extender. The teres major will also be an internal rotator. Okay, so let's talk about how this rotator cuff gets its blood and nerve supplies. We'll start up high here. We see the suprascapular artery and the suprascapular nerve. Remember also we have this superior scapular notch or suprascapular notch with the superior transverse scapular ligament helping to form almost a foramen here, if you will. The suprascapular nerve, which comes off of C5 and C6, is really going to be coming off what's called the upper trunk. Sorry for my writing. it's going to come off that brachial plexus off very high, loop around, and go underneath this ligament. So you can see it's going through the notch. The suprascapular artery comes off the subclavian artery anteriorly, pretty close to where the subclavian starts to go underneath the clavicle. And it comes posteriorly and goes over this little ligament. So we use a little mnemonic. Army goes over, Navy goes under. That makes sense, right? So the Army goes over this bridge of a ligament, the Navy goes under that bridge of the ligament. And they both are going to service the supraspinatus muscle once they enter into this supraspinous fossa, which is up in this area. And then they continue on laterally and inferiorly and go through the greater scapular notch to get into this infraspinous fossa to help service the infraspinatus muscle. So both the supraspinatus and infraspinatus are served by the suprascapular artery and nerve. Moving down, we have the teres minor muscle. Teres minor muscle is going to be served by these two structures, the axillary nerve and the posterior circumflex humeral artery. The axillary nerve is one of the terminal branches of the brachial plexus coming off what's called the posterior cord. We'll see that in another lecture. Posterior circumflex humeral artery comes directly off the third part of the axillary artery. So we see axillary a lot because we're basically in the axilla up in this region, just anterior to this muscular wall. So this axillary nerve is going to go through this little space here. You can see this space has 4 sides. This is called the quadrangular space. Okay? I'm just going to put a Q for quadrangular space. So does the artery. So they course together. This is a neurovascular bundle coursing together and going through this quadrangular space. And as it's coming through the space from anterior to posterior, it's branching and giving off a branch to the teres minor muscle. The artery is giving off a branch to the teres minor muscle. And it continues on to service the larger muscle in this area, the deltoid muscle. Note we also have highlighted a circumflex scapular artery. We'll get a better idea of where this circumflex scapular artery comes from, but note we have a small little space here. This is a triangular space. Through this triangular space courses the circumflex scapular artery. It's going to come out and service some of this musculature back here as well, including a bit of the infraspinatus teres minor and this non-rotator cuff muscle, the teres major. Looking anteriorly, first let's appreciate that axillary nerve coming off and going through that quadrangular space. So again, I'll kind of outline that space. So we have that axillary nerve going out. Once again, this is a terminal branch of this brachial plexus. We have this axillary artery coming down, and as it courses into the arm, let's draw that down, it's going to give a branch that goes into that space as well. That's that posterior circumflex humeral artery. Now let's turn our attention to the subscapularis muscle. We can see the innervation of the subscapularis as being 2 nerves, the superior and inferior subscapular nerves. They also come off this part of the brachial plexus. It's called the posterior cord. We'll see this in the next discussion, I believe, in the axilla and posterior triangle. But this is the posterior cord, this thicker yellow structure here. And so we have this superior subscapular nerve. We have this inferior subscapular nerve. Note we have a middle subscapular nerve as well. That's also known as the thoracodorsal nerve. The arterial supply for the subscapularis is from various branches of the axillary artery. So here we see those other 2 muscles that are not part of the rotator cuff. We see this very broad muscle, the deltoid, and then we see the teres major muscle. In this image, we barely see the teres minor. It's right up under there. It's that little, almost triangular shaped muscle. Most of this is your infraspinatus, some of which is underneath the trapezius muscle, and some of which is underneath the deltoid muscle. And then we have this very robust teres major muscle. Here we see some views of the deltoid muscle. Over here we see some fibers that run anteriorly, laterally, and posteriorly. Notice the broad origin. You can see this broad origin here shown in red. We have much of the scapular spine, the acromion process laterally, and the lateral third of the clavicle, though we don't necessarily see it on this view here, but we have the lateral third of the clavicle. You can see that over here and a bit over here as well. So this very broad origin. You can imagine that these fibers here have different actions than these fibers here. So moving down in this area, these fibers will be able to flex the shoulder, so bring the shoulder forward. If the shoulder was positioned forward, let's say like that, these fibers would be able to pull the shoulder back. So the anterior fibers would be able to flex the shoulder, and in a flex position the posterior fibers would be able to extend the shoulder. Now certainly from this position in the anatomic position, the posterior fibers could still extend a little bit. Of course, these lateral fibers will be able to abduct the arm, so bring the arm out that way, with the help, as you may recall, of your supraspinatus muscle that's inserting onto the greater tubercle. So in summary, the deltoid does a heck of a lot of stuff. It flexes, it extends, it abducts, and it can even help to medially rotate with these fibers or laterally rotate with these fibers. Here we're revisiting that teres major, again not part of the rotator cuff. This teres major is coming from the lateral border of the scapula, inferiorly, more inferior than the teres minor, and it's extending outward to the humerus, but not onto the most proximal part of the humerus, but down in here onto the shaft of the humerus. But note it goes into the armpit and attaches again on this medial lip, but anterior on the medial lip. You can see that here as well. And if we look at the anterior view, we can see that that connection point is out here. Therefore, it can be an internal rotator. So we have that here as an internal rotator. But note its primary action is adduction, especially in the frontal plane. So if this arm was abducted already, it certainly would be a nice strong adductor. Or if it was flexed, I don't have a viewpoint here, but if this person was, that's a person, if this person was flexed, it would be a strong extender of the shoulder, of the humerus at the shoulder joint. Innervating the deltoid is that axillary nerve that we saw earlier coming out through this quadrangular space. It innervated the teres minor, and it also sends a very large branch to innervate the deltoid. The teres major is innervated by the lower subscapular nerve. So recall that we had the upper subscapular nerve innervating subscapularis. We had the lower subscapular nerve innervating subscapularis as well, but it also continues down to innervate the teres major muscle. Remember that the middle subscapular nerve is also called the thoracodorsal nerve and innervates the latissimus dorsi muscle here. I'm only going to glance over the blood supply. We have this large deltoid muscle in the region. We can see the posterior circumflex humeral artery coming out of this space called the quadrangular space. Now this artery certainly could contribute to the blood supply in the region. We have an anterior circumflex humeral artery as well on the other side that we can't see right now. It would be wrapping right along this area. Certainly that could give off some vessels to the deltoid. We have a deltoid branch coming off the thoracoacromial artery as well. In other words, the deltoid is going to take blood from any vessel in the region. Similarly, the teres major muscle, as it courses through here, might get blood from any of these vessels. Here are 3 vessels. I only have 2 listed, but here are 3 vessels. It could take blood from any of those coursing through the area. Now this slide is dedicated to the quadrangular space. I really want you to know that there is a space generally where it resides. The boundaries, I don't want you to spend so much time focusing on the boundaries. Really, I want you to know generally where it is. So it's obviously in this region. It's bordered by the teres major minor, the humerus, and the long head of the triceps. So it's in this region, and I want you to know its contents, that it contains the axillary nerve and the posterior circumflex humeral artery. If you have a proximal humeral fracture, certainly this axillary nerve could get damaged. If you have hypertrophy of the muscles in this area, let's say a bodybuilder, that this area is going to get completely closed down, and theoretically you might get a little compression of the axillary nerve and maybe of the vessel as well. During these last few slides, I'd like to go over some of the muscular pathologies in the shoulder joint. So here you can see some listed: the rotator cuff tear, the supraspinatus tendinopathy, shoulder bursitis, and bicipital tendinitis. These all can produce shoulder pain, lateral shoulder pain, maybe even anterior shoulder pain, depending on the person and the extent of the condition. So a rotator cuff tear is just a general term. It could mean that any of the 4 rotator cuff muscles are affected. So here we see one rotator cuff muscle, the supraspinatus. That's generally the muscle that's most affected when you hear someone has a rotator cuff tear, but it's not always the case. So what can happen to the supraspinatus? Well, you can have some sort of irritation of the muscle, overuse of the muscle, but more commonly you get some irritation of this area where the muscle starts to become tendon before it inserts onto this greater tubercle. Overlying this muscle is a bursa. Now, a bursa is generally a small sac that could potentially fill with some fluid, but it helps tissues that underlie bone glide back and forth underneath this bone. Now the artist has shown this space between the muscle and the acromion process. Realize that in many individuals this space is very, very small, and therefore this tendon could get irritated as it presses up against the acromion. It could be the tendon, or it could be the bursa that gets irritated and fills with fluid, thus further compressing this space. Further anteriorly, we have this long head of the biceps tendon going through the bicipital groove, or the intertubercular groove between the greater and the lesser tubercle. So this tendon can get quite irritated. So imagine you have an irritated supraspinatus tendon, and this really helps in those first 10, 15, 20 degrees of shoulder abduction. But imagine you have this irritated, and so it doesn't want to work. You try to get some of that abduction or abduction/flexion movement through your long head of the biceps tendon. Therefore, this tendon gets overused, so you could have a combined supraspinatus tendinosis, or degeneration, or tendinitis, inflammation, or a combined condition there, along with an irritation of the biceps tendon. So that would be a bicipital tendinitis. So typically, if you have patients with anterior shoulder pain, you press on this tendon with your thumb. You might make them jump through the roof. That's indicative of a bicipital tendinitis. Rotator cuff tendinitis is one of the most common things you would see in a clinic. People with shoulder pain often have some sort of rotator cuff tendinitis. Now this happens in the young population or in the older or middle-aged populations. So it happens across the board in people who are athletic and people who are not athletic, due to overuse, reaching overhead, due to common ADLs or activities of daily living, reaching behind the back, wiping, cleaning, etc. The supraspinatus, once again, has very little clearance underneath the acromion process, as well as, we don't see it here, but the coracoacromial ligament. Here we can see the greater tubercle very far away from the acromion process and the coracoacromial ligament. But as we abduct, this greater tubercle ends up invading some of that subacromial space, and we can see that greater tubercle right here invading the space and creating even less space for this tendon to glide through. Therefore, we get this compression point right up in that area, and with repetitive use that can degrade this muscle/tendon. Of course, a few factors can contribute to this. Maybe with age we just end up having reduced space in this area. Why might that be? Well, I'm looking at this one right here. There might be a spurring of the acromion, so instead of a nice clean bone like this, there's a little extra spurring of bone in that area, thus reducing the space. You might have impaired use of other muscles that help with external rotation. Here we have these two external rotators. External rotation during shoulder elevation, usually in the abduction motion, is quite helpful in clearing the greater tubercle from the acromion process. You can try this by abducting with your arm internally rotated, i.e. your thumb pointed down, or abducting with your arm externally rotated or your thumb pointed up. You can see how much higher and how much easier it is to abduct with your thumb pointed out. So therefore you want good control of your infraspinatus and your teres minor. As you already know, the upper and lower trap helps to upwardly rotate the scapula, i.e. the glenoid fossa or glenoid cavity goes upwards. Here we see the upper fibers grabbing onto the scapular spine, and then the lower fibers coming around to help spin as well. Now, if you have impaired use of the upper and lower trapezius, you have impaired the ability of the scapula to upwardly rotate. And this upward rotation is needed when you're performing shoulder abduction. So here you can see in 90 degrees of shoulder abduction, 60 degrees actually come from the glenohumeral joint, while 30 degrees comes from the upward rotation of the scapula. So here we see a nice MRI of a normal shoulder. This is the supraspinatus tendon labeled as rotator cuff. This is the acromion deltoid, head of the humerus, glenoid fossa. Note the consistent coloring of the supraspinatus and its tendon over in this area. Here we can see a damaged supraspinatus, damage within the muscle, and you can see brightness here indicating damage or inflammation around the tendon itself. This individual most likely has shoulder pain, has disuse of the supraspinatus tendon, so has difficulty with abduction. Probably has some sort of impingement, so as they raise their arm up, they're going to have pain with their arm at 20, 30, 40, 50 degrees of abduction, and even more pain as they get higher up in the abduction or flexion realm. Also probably have a hard time reaching behind their back. Well, that does it for our discussion on the posterior shoulder. Please let me know if you have any questions or concerns. You can always email me or come to my office.